Hey, fatty, stop eating.
I don't want to judge, but if you realize that you're becoming bigger and bigger, maybe you need to do something about it.
It's a mindset thing. You just have the right mindset and you can accomplish anything.
Do exercise. Zumba, for example, like me.
And I know, it's not politically correct, but...
Take responsibility.
I mean, they're not ugly, but...
Everyone has 20 minutes to do something.
Don't eat a burger every day, or, I don't know.
Just stop eating. It's that simple.
Okay, Bryce, just wanted to read from the teleprompter.
Right here?
Yep.
All right. I am here today to talk about something we have neglected for far too long. Why the SIBO?
White SIBO causes 2.8 million deaths every year.
It is heavily affected by our genes, the hormones, and the environment we live in.
And there is not a single country in the world that has reduced the number of people suffering from SIBO for over 30 years.
When you suffer from this disease, it impairs your body's normal functioning, and it's very hard to fix yourself.
Studies show that 40% of people living with SIBO experience judgment and humiliation,
Making them feel ashamed and afraid to ask for help.
Today, about 650 million adults and 150 million children live with it.
Living with white SIBO is a health issue, not a character flaw.
It is time to rethink what we know about obesity. Y'all could... Oh man, we talking about obesity?
Oh, it was back to front.
This is a joke.
I feel really bad. I technically body shamed him, kinda.
it's funny because we just judge, like without even thinking about it.
It's more than just a diet and exercise. It's a really serious disease. I'm sorry, guys.
How does that make you feel?
I feel bad, like I'm part of the problem. They're sick, they're sick, they're suffering, and I'm judging them and saying, oh, stop being lazy. Like even my own brother. But I ain't know. I really didn't know, man.
Well, I think it's maybe important to rethink how we can help people.
All right, so just an interesting way to relook at this problem. When we're so used to using the term obesity, it's a different way to look at this issue. So with that, I would like to turn it over to Dr. Moore, who's our medical director, and he's going to give just a few opening words and then also introduce our two fantastic speakers that we have lined up for today's presentation. So Dr. Moore, I'll turn it over to you.
Thanks, Matt. Thanks everybody for coming. As a little background, we here at the Kansas Business Group on Health have CDC funding for a couple of grant projects, both of which focus extensively on diabetes prevention. And if you've spent any time in the diabetes world, you know that diabetes prevention and obesity management go hand in hand. So I'm excited to hear what our speakers have to say today. According to my agenda here, I believe Abby is our first speaker. Is that right, Matt?
Actually, Dr. Fitch will kick us off.
Okay, sorry. I maybe had an old copy. Dr. Fitch. So let me introduce Dr. Fitch. Angela Fitch is the Associate Director of the Massachusetts General Hospital Weight Center and faculty at Harvard Medical School. She's board certified in obesity medicine, internal medicine, and pediatrics. She's a fellow land grant graduate along with me from Iowa State University with a bachelor's degree in chemical engineering. She worked for Procter & Gamble as a product development engineer before following her passion and attending medical school at the University of Cincinnati College of Medicine. She then stayed there for a combined residency in internal medicine and pediatrics. She was chief resident in internal medicine before moving to Minnesota to practice primary care at Fairview Health Systems and the University of Minnesota. There, she developed her skills and passion for treating obesity in the primary care setting and began the practice of obesity medicine at the University of Minnesota, treating children with obesity. In 2012, Dr. Fitch became the medical director for the Metabolic Health and Weight Management Clinic at Park Nicollet and began practicing obesity medicine full-time. She became a diplomat of the American Board of Obesity Medicine in 2012 and moved back to Cincinnati to create a multidisciplinary medical surgical weight center. There, she was appointed medical director of the Executive Health Program and vice president of primary care before moving to Boston. She's currently serving as vice president of the Obesity Medicine Association and previously served as secretary treasurer and trustee. She was the 2015-2016 chair of the clinical management section of the Obesity Society. She's the winner of the 2017 Clinician of the Year Award from the Obesity Medicine Association. She enjoys seeing patients of all ages to help them reach their weight and wellness goals. She enjoys cooking, traveling, and outdoor activities with her husband and son, and she looks forward to exploring New England. With that, I'll turn it over to Dr. Fitch. Thanks.
Thank you for that very nice introduction. I appreciate it, and I do miss the Midwest, so a little place in my heart for that. And I'll share the screen here with some slides that I created, but please feel free to ask any questions that you might have. All right. Okay, that should be good, right? You guys see the slides? All right. And you see it just in regular view, right? Like with the slide up in the screen?
We are seeing presenter view, Dr. Fitch.
Okay, let me see. Let me see how, hold on, let me change that. That is due to my computer. Let me see how I got this new computer, so you have to bear with me. Let me do this, and that should work. How about that?
That's perfect.
Is that better? Okay. All right. So the title today that I like to speak about, which somewhat was in the little video that was shown, right, is obesity. It's your chemistry, not your character. So much of obesity has been put onto patients themselves as something that they should be able to fix by themselves. In fact, I get a little teary every time I watch that video because I see people all the time that struggle with this issue, you know, that feel like they should be able to fix this themselves and that they're just inadequate in some way, when we know that it's a lot more than that. These are just my disclosures. I serve on some advisory boards, which won't matter here. This slide should be moving to show you the progression of obesity from 2011 to 2019. You can see where the states are getting more orange and getting more red as we progress across the timeline, especially in the South, and then in Kansas there turns red, which is greater than 35% of the population, adult population, struggling with obesity by the time 2019 comes along. It's expected by 2030 that in the country, up to 50% of people will struggle with obesity by 2030, which is really a big, going to be an even bigger pandemic than we're struggling with now. This is some of the data I pulled out from Kansas from a pediatric standpoint as well, right? Pediatric obesity is also a struggle. So not only do our adults struggle with obesity, but our kids are even more importantly struggling at a younger age. You can see here that the yellow is nationwide and the blue is Kansas. And you can see where from an overweight standpoint, 18% of kids versus the national average of 15. And you guys do a little better in the obesity category with about 11% of children ages 10 to 17 with obesity versus 15% of the nationwide population. And the big thing to know too is that adult obesity is a pediatric disease, meaning kids with obesity do not outgrow their obesity in general. So if you have obesity here, you can see on this slide, in the especially the severe obesity, the probability of obesity at 35 years of age is pretty much, you know, almost gets close to 1 by the time if you have obesity as a child, especially severe obesity or even a moderate obesity, which is in the red. So again, it is a problem that's not just going to go away or get better without some sort of intervention. You can also see by this next slide here, this next part here on the right-hand side, that there are also racial disparities as well. And there's also economic disparities as well, where Black and Hispanic groups struggle more with obesity, even into adulthood here, as you can see, versus white and other populations. So there is this issue that we also see as early as early childhood as well as it goes on into adulthood. The pandemic is providing us some other challenges, right? So in a recent study in JAMA, they actually looked at data from connected scales. These scales were part of a study done in a heart for a heart health study. So these patients were actually receiving some intervention at the time around sort of being healthy, right? Not necessarily specifically weight loss, but they were in a study. And in this scale data, this is direct data from people getting on the scale every day, there is on average a 1.5 pound weight gain per month seen during the pandemic, which if you extrapolate that over a year, that's over, it's close to 20 pounds in a year. You can see here by a survey of the American Psychological Association just very recently done, the results just recently released, showing that on average, US adults, 42% of US adults reported undesired weight gain of, on average, almost 30 pounds. You will note that there were 18% of people that also reported undesired weight loss. So in our country, we have a very strong dichotomy of people that struggle with food insecurity at times and are experiencing a 26-pound weight loss, and other people who are experiencing a 30-pound weight gain. The gain being more prevalent, especially in the millennial population, which is the ages of 25 to 42, with a 41-pound weight gain on average in 48% of the population. Our essential workers are also feeling more of this stress as well, with 38-pound weight gain on average in 50% of those people. So again, a serious problem as time goes on, just to put some light into it. The ultimate challenge too is that, as we talked about, people feel like this is a character flaw. While 65% of people with obesity now feel it's a disease, it was declared a disease by the American Medical Association in 2012. But while 65% of people believe obesity is a disease, still 82% of people feel that it is their own responsibility, completely their own responsibility to fix that disease. We don't have any other diseases like this. This is, people don't come in with cancer thinking they need to fix their cancer themselves. They recognize there's treatment, there's effective treatment that's going to make that disease better, and they, get that treatment given to them. And so again, this is an issue that we need to work on as time goes on. The definition of obesity is a disease in which excess body fat has accumulated to a level that may have an adverse effect on health. This is really about our fat, not necessarily our weight. And that's something that we look to in the future to really start to focus on more as we're getting more technology to actually look at people's body composition and not just their absolute weight. But for now, we typically use BMI to address the disease of obesity, or to classify the disease of obesity. And we're going with class 1, class 2, class 3 obesity now with BMI, you can see there in the slide, because again, this is less stigmatizing than other types of descriptions of obesity, like morbid obesity, et cetera. So having these classes of obesity similar to stages of cancer, for example, help to risk stratify. So people in class 3 that have class 3 obesity have many more diseases associated with their obesity than people in class 2 or class 1. It's important to note also, this is a chronic, treatable, multifactorial disease. Here you can see on this obesity systems maps, there are people that do systems mapping of how systems interact with each other. And these are all the interactions with obesity at the center, right? So these are all the little lines that you see on this, is how somehow our weight and our food intake, our biology, our genes, our societal influences, stress, sleep, other things interplay to make obesity so incredibly complicated. You would see a similar map for something like cancer or other types of diseases where there's multifactorial reasons for having this issue. The other thing that we know quite scientifically, and this is where it is about your chemistry and not your character, right, is that when you decrease your calories and you're eating healthier and making different choices around Eating more vegetables, for example, to feel fuller on less calories, right? A lot of the food we have today is very energy dense. Unfortunately, it doesn't take up a lot of space. And so therefore we have trouble with having too many calories in one sitting. But as you change your calories, as you increase your activity, unfortunately, your body responds on the other side with slowing down your metabolism, increasing your hunger hormones, and decreasing your fullness hormones. So all of these things play a role in this tug of war to make the patient that has lost the weight then more likely to regain that weight in the future and make it harder to keep off. And this is our sort of ultimate challenge as we talk about treatment. The idea is too that then people have a set point, unfortunately, that is genetically set. So if you picture the set point as this thermostat here, and the lines on this thermostat, you know, this colored bar as the range of degrees of genetics, you know, affecting obesity. And then you layer on top of that things like our processed diet that I mentioned, that's very calorically dense, irregular eating patterns, skipping meals, then getting overly hungry and eating larger meals, especially in the evening. So timing of eating is also a factor. So quality, quantity, and timing all play a role in our eating. We don't have enough time to eat, that creates a problem. Inadequate physical activity, as we discussed, right? So actually sitting, not even the fact that we're not being active, but sitting actually promotes fat storage. So the more you sit, the more your body wants to be in an energy storage mode. So getting up, standing up, et cetera, can be helpful in the work environment, for example. Inadequate sleep. So sleep, when we don't sleep well for whatever reason, whether that's from menopause or from small children waking up in the night or from alarms going off, or I know people who have to work, you know, at all hours of the night because of various reasons, right? That creates an obesogenic issue as well, that makes your body store more energy as fat. Stress does the same thing. High stress levels, not de-stressing, you know, having things like meditation or other types of ways of calming your stress in your body can be helpful. But that increased stress can also lead to more weight gain, independent of everything else that a person is doing. Weight increasing medications are also a problem that we look at when we're treating people with obesity and trying to switch those medications out for something different. And then life changes, things like aging, pregnancy, menopause, as we talked about, are real issues that you can't really fix. So all these things play a role in increasing that set point, right? Making that set point higher than we want it to be. And so then making it harder even to get back down to a weight that would be more normal for our body, for example. This just gives you some other visual of that. If you have a relatively unhealthy lifestyle and your set point is up in this larger range, up at a BMI of 46, say, for example, you institute a healthy lifestyle, you're able to move that down a bit, maybe down to 42 with that lifestyle change. But your set point, this colored bar, hasn't really changed. You haven't changed that. You just moved yourself down here and you're still in this tug of war that you're playing every time. By adding medication to that, we can actually move that set point. And now the person is able to lose more and be able to keep it off greater because that set point, that colored bar has actually moved. Surgery is our most effective tool of moving that set point, right? So when we have surgery, we really exert a lot of power on changing the set point and moving this set point back so that the patient is able to be more successful into these lower BMI zones. So these are the tools that we have available to us, you know, in our treatment strategies. But doing it alone, sort of up here at the top, right? Free living in the obesogenic environment that we have today is what's producing 50 to 75 to 80% of people not being a healthy weight. If you look at overweight combined with obesity by 2030, right? So our environment is producing, you know, over 50% of people struggling with excess adiposity or excess fat storage. When the environment is automatically producing that, it makes you have to live differently within the free living environment, and that's what's so challenging for people to do. The other thing to recognize that you may be aware of from what's been on the news is that there's a strong interplay between COVID-19 and obesity. And that's where there's been some recent articles published around this idea of a syndemic, which means there's two pandemics overlapping each other, which is the idea that we have obesity, and then on top of that, we had COVID-19. When COVID-19 hits a person with obesity, There is massive adipose inflammation that's already there to begin with. Adipose is our fat tissue. There are immune impairments that are already present from the obesity itself, but then when COVID attacks, it adds to this metabolic dysfunction. So this metabolic dysfunction, again, that's there at baseline is like extrapolated by 20, 30 fold. And patients have this sort of acute syndrome. We're seeing people acutely diagnosed with diabetes, for example, with COVID-19 because of this metabolic dysfunction that's happening very suddenly. All of this leads to increased hospitalization, increased ICU, increased mortality, et cetera. This is just a slide from the CDC showing that with severe obesity, for example, you are 4.5 times more likely to be admitted to the hospital with COVID-19. And then as you layer on other conditions on top of that, that increases your risk of hospitalization. You can see that severe obesity, or what we would call class 3 obesity, BMI greater than 40, is actually a higher risk factor than diabetes itself for needing to be in the hospital, related to this adiposity reaction of the virus with our fat tissue. And that's the issue here. You can see here in this study from the Annals of Internal Medicine that the increased risk here, where the risk ratio for people younger than 60 is anywhere from, for a BMI of 35 to 39, is almost threefold the risk of someone of normal weight. And same with, as you go up in BMI greater than 45, for example, 12 times the risk of dying of COVID. This is mortality of COVID-19 related to that BMI factor in and of itself. So that is something that, you know, has come out. And again, you know, had we known this data very early in the pandemic, had people been able to access effective treatment very quickly, they can't get surgery very quickly just because of in fact, our surgeries were all shut down for quite some time because they are considered elective surgeries, interestingly. But if some of these people were to have had medication early on in the pandemic, they could have potentially lowered their BMI, you know, into this. You could take a person, for example, with a BMI of 35 and very nicely get them into a BMI of 30 category, or even under 29 in a 6-month time frame, and you could have reduced their risk by several fold of dying of COVID. So it is a very interesting thought process. I mean, obviously hindsight is 2020, but having access now in the future going forward to treatment, I think is going to be even more important. And what works for obesity treatment is I use this acronym SAME to make it easy, because I need easy things to remember, right? And it needs to be the same, because the more that we do things the same, the better off we are, right? So we need structure, which are our weight loss programs, right? Meal replacements also provide structure. So things like Nutrisystem, Jenny Craig, things that give us a prescriptive nutritional intervention can also be helpful. These are delivered also in multidisciplinary weight centers like we have at the Weight Center at Mass General. People need accountability, which is the idea of coming in to see somebody, right? Virtual care has been very helpful in increasing this accountability, as well as all the technology we have. These connected scales, my hope is in the future that we'll have these connected scales that will be able to, you know, tell us when our weight is going up and alert somebody, right, that that's happening so that we can get attention to that when needed. We need metabolic alterations to promote fat loss. Like I said, our body's natural metabolism has this set point that wants to hold on to fat storage. This is a normal a thing that was good for us back in the day, right? If we were, I was an engineer, right? So by training, if we were metabolically engineered to lose weight, we all wouldn't be here today, right? We would all have evolved off the face of the earth. We were metabolically designed to store energy so that we could go through times where we didn't have food. That doesn't exist today for most people. And so again, having this, promoting a metabolic alteration, which is with surgery and medications predominantly. Dietary patterns also promote a metabolic advantage. So things like not eating late in the evening, for example, the later you eat into the evening, the more you tend to store that energy as fat. Exercise intensity can play a role, as well as sleep, as we talked about in stress management too. The other thing we have to have is this environmental control, right? As we mentioned, the environment we currently live in is very, by its nature, currently today is very obesogenic. So a lot of processed food, a lot of things that provide a lot of calories in a small amount of volume, which is one of our biggest issues. So having attention to that and changing that environment and making those things, not as available, for example, or not around us all the time, can be helpful. This is just a nice algorithm that was put forth in this practical guideline for mostly for primary care physicians to treat obesity better too, because as a primary care physician, that was one of the reasons I went into obesity, because I was so fascinated by this idea of the set point and our metabolism and diabetes and how that all fits together for energy storage. And so, but most primary care physicians don't get a lot of education in obesity until now, right? We're kind of behind the 8 ball as it relates to, getting the word out on how to treat it. So having some of these guidelines, this is this A, B, C, D, E, F sort of approach, right? Asking permission. So not stigmatizing people, because, it is a choice to decide if you want to work on it or not, right? And so, mentioning that, saying your weight's been increasing, this can lead to other health problems. Would it be okay if we worked on this together? That acknowledging that there are ways to work on it, that there's actually treatment that could be more effective than what people are doing by themselves. Providing that education is key. And the biggest thing too is escalating treatment when appropriate. So again, we have this challenge that people tend to think that they're just going to be able to treat this themselves. And so we need to be as providers, as clinicians, whatever clinician, dietitian, psychologist, obesity medicine, like we are, primary care, acknowledging that there's more effective treatment, there's more medications and other treatments that can be employed, to get better results when people are ready for that and entertaining that. And this treatment pyramid sort of gives you an idea of this treatment strategy and this shared decision making that we do with patients. We do shared decision making with every disease that we have, right? There's risks, there's benefits to any kind of treatment, and we need to understand that. And with obesity, as our health risks and as our BMI in particular, or our adiposity increases, right? As we get more health risks and as our BMI gets higher, BMI greater than 40, class 3 obesity, BMI greater than 35 with some sort of comorbidity, sleep apnea, hypertension, fatty liver disease, et cetera, warrants surgery as an initial consideration, because for these diseases to get better and for the BMI to drop into a range that is more healthy, it requires about a 30 to 40% weight loss for that to occur. A 30 to 40% weight loss is really hard for the human body to undertake and to maintain. And so again, surgery is the most likely tool that's going to produce on average a 30 to 40% weight loss. So when you need that 30 to 40% weight loss, I have a patient, BMI greater than 45, that really needs to have a heart transplant. In order to have a heart transplant, he needs his BMI under 30, right? Or under 35 in order to do that. So he needs to have a 30 to 40% weight loss. And if that's what he needs, then he's going to need surgery to most likely get there, because some of our other treatments just do not produce that much weight loss that as what that surgery entails. So we need to increase this treatment intensity, right, as the disease gets worse, which we do with several other diseases. As I mentioned with cancer, for example, if you have metastatic cancer, you're going to get a much more aggressive treatment protocol than someone who has sort of a spot, that they need to have removed, for example, from their skin or something, right? So that treatment is very different than a treatment that has a more disease intensity. But we do have some good medications today, thankfully, that are producing closer to a 20% weight loss. And so again, for patients in this BMI category greater than 30 or greater than 27, even with a comorbidity, so greater than 27, for example, with sleep apnea, right? It would be indicated to add medication, because again, to resolve these comorbidities, you need more weight loss into this 10 to 20% category. And that's how you're going to get it, is with something like medication. Prescriptive nutritional interventions are, like I mentioned, are meal replacement type programs. This is being launched now in the UK. The UK has decided to provide an OptiFast program, which is a meal replacement program, to all of its citizens who have newly diagnosed diabetes, because there's been some good data to come out that when you treat diabetes early, when it's first diagnosed, you then get better results around disease remission. which is the same with obesity actually as well. I have this discussion with a lot of the young people that I see, especially our adolescents who have severe obesity already, right? We have data to show that the earlier we treat them with some sort of treatment, the better off they do. This is, again, the idea that obesity is undertreated. If you look at the amount of people that it's indicated to take anti-obesity medication, so that's BMI greater than 27 with a comorbidity, so that takes you up about 45% of the US population would fit into that category of indication. Only about 2% of people are actually treated with effective pharmacotherapy that can produce those greater results. Whereas if you look at a disease like diabetes, yes, there's a lot less people that have it. There's only 10% of people in the country that have type 2 diabetes, but most of those are treated with medication because, again, it's seen as a disease that is warrant of therapy. And that's where we're trying to change the paradigm for obesity treatment as well. Because there's some data to show, this is the scale maintenance trial with the drug liraglutide at 3 milligrams, which was our first GLP-1 agonist that was available for the treatment of obesity. These drugs were in general on the market early on for diabetes treatment, but then it was recognized that they produced a substantial weight loss. And so therefore they were then brought to the market for obesity. So liraglutide, this study shows that these were people that actually were good at losing weight. So they had lost 5% of their weight initially. And then they were randomized to either placebo or to drug therapy. The drug therapy is the pink line. And you can see where the placebo people, while they lost a little bit more, and again, they're in a program, they're in lifestyle counseling, they're coming in each week. So they're getting a lot of support and accountability, right? They're getting the structure, they're getting the accountability, they're getting the environmental change. They're just not getting the metabolic advantage that the drug is giving these other people. The people with this metabolic advantage on this medication then were able to lose an additional 6% of their weight. Here at this data point in time is where these people that were on drug treatment were actually randomized back to placebo. And you can see where their weight started to creep back up again, which also identifies that if we're going to treat a disease like other diseases we treat, we do have to think about this long-term and treat it long-term. Here's a little bit of a confusing table, but let me just walk you through it because what I want to, again, highlight is the benefit of medication and, again, of surgery here. So if you look at this, we talk about this now as categorical weight loss. So how many people are able to lose 5%, 10%, 15, 20, and 30? And why do we care about these higher percentages, right? Well, we care about these higher percentages in particular because these higher percentages, these 15 to 20%, is where we see the most disease resolution. It takes a greater than 10% for sure, closer to 15% to resolve fatty liver disease. Fatty liver disease is now in the next year or two going to be the #1 reason for liver transplant in our country, a very expensive and very life-threatening and challenging thing for someone to go through a liver transplant. So resolving that fatty liver disease, getting into these 15% categories is where we see more disease resolution. Same with diabetes. For diabetes to go away, we need a greater than 20% weight loss consistently over time. And that is, again, you can see here, best accomplished actually with surgery, because this is 10-year data with surgery, whereas most of the other data in the table is only 1 year, just because that's the kind of data we have with behavior programs and with medication. So 72% of people are able to reach this 20% with surgery. 10% of people are able to do that with Weight Watchers or some sort of intensive behavioral therapy. That's what that stands for. A lot of this data comes from Weight Watchers because they have very nice data set. So again, 10% of people are able to do that 20% with a lifestyle intervention. If you combine that with medication, for example, here with semaglutide, which is a new medication expected to come on the market. This is from early phase 3 data, but this medication will be expected to be on the market in June. And if you look at this, it's really going to be a game changer in that instead of 10% now, we have 36% of people that are going to be able to get into that 20% category. Whereas with our current medication on the market, for example, phentermine topiramate, which is our oldest medications that we've had around, this combination of these two medications. We've had phentermine since 1956. We've had topiramate for quite some time as well. Topiramate was a seizure medication and is now used predominantly for migraine prevention as well as for weight management. And you can see here where 15% of people at least, which is better than 10, right? So we can get more people into these higher categories, especially if you look at some of the data falls out in these higher categories, which is harder to predict. But even at the 5% category, which is good for diabetes prevention, right? So 5% weight loss reduces your risk of getting diabetes by 58%. So if you can just lose 5% and keep it off for the rest of your life, if you have obesity or overweight, right? You do that and you reduce your diabetes risk by 50%. Well, still only 48% of people are able to do that in a behavior program, right? But we can get that with medication like we have today, for example, which is liraglutide here. You know, we can get, when we combine this intensive behavior therapy or some sort of type of lifestyle intervention with the medication, we go from 48% to 74%. And same with the phentermine and topiramate, you know, we're getting up into the 70s here instead of the 50s, right? So we're getting not quite, you know, twice as many, but we're getting a substantial amount of people increased into this category here, 25% versus 52 versus 50. So again, doubling the amount of people that can get into that 10% category with these treatment interventions. Same with our other medication, bupropion and naltrexone that we have on the market. Not quite as good, you can see, not quite as much weight loss power. You're in the 40s and 20s versus the 60s and 40s, but still is an effective tool for a lot of people. This is the just recently published March 18th of 2021, the semaglutide data, which is going to be our newest medication, fingers crossed, approved by the FDA any minute now. Average weight loss 17.4% here. You can see here too, when people these patients were taken off the medication, so they were switched to placebo at week 26. They regained most of that weight that they had lost. So that just shows the need for continued treatment of using medication if that's helpful for patients. The other new thing we have on the market is a medical device actually that's called Plenity. And Plenity are capsules. They're hydroxycellulose capsules. They're pictured here, and they come in this little container. And you consume them prior to lunch and prior to dinner. They expand in your stomach like a bunch of vegetables. So it'd be like if you ate a big spinach salad or something, you know, to also take up that space, right? They expand in your stomach. And again, they're able to help more people. Here's placebo, you know, 15% of people getting into the 10% category, whereas with the Plenity, almost 30%. So almost double the amount of people you're able to get into the 10% category with this. Technically, it's a medical device and approved as such. This Plenity is not covered traditionally by insurance, which is similar to our endoscopic procedures that we have, like the gastric balloon, et cetera, that are not covered by insurance, but is another tool for patients, certainly in our toolbox, especially because it doesn't get absorbed, you know, so that it doesn't have as many side effects directly, you know, because it's not going into your bloodstream, et cetera. So it's very safe for people to use. It's staying in your intestines predominantly. The other thing to remember is with all treatment, whether it's cancer or heart disease or hypertension or, you know, whatever disease that we're treating, right, in medicine, we know that there are responders and non-responders. So this is what we call a waterfall plot. So when we do a study, if this was the study we just saw with semaglutide, for example, you would have people over here on this end that are responding with weight loss. So this is total body weight loss. And again, you would see that there are these people that are almost even hyper responders, people that do really, really well. And then there's people here that are gaining weight. So again, the more people you can get on this side of the equation, of course, the weight loss side is what we're looking at when we're looking at this medication efficacy or this treatment efficacy, whatever treatment it might be. This could be surgery, this could be, you know, whatever treatment. There are always responders and non-responders. We don't formally understand that right now. As to why these people don't respond, right? Just like people don't respond to blood pressure medication. They don't respond to cancer treatment sometimes, right? Their cancer doesn't go into remission. It's the same thing. It's a genetic, it's a medically complicated reason. But the biggest thing to reiterate to people is this is not success and failure. Like in other words, people over here tend to think it's somehow their fault because they're not responding to treatment. But thankfully, that's why we have multiple medications and now newer medications even, as well as there's newer medications even down the pipeline that are going to be just as good as semaglutide. So there's going to be a lot more of these types of things available to us, to help people figure out, where they're going to fall on this curve and where they're going to respond to what. To highlight pediatric obesity real quick, we diagnose pediatric obesity. This is an example of a growth chart. For those of you who have children, you will probably recognize at least the growth chart concept when you go into the office. We want you to track along one of these lines, right? And we want you to kind of, consistently be on one of these lines. This is the BMI growth chart. And when a BMI is greater than the 85th percentile, then that's this line here. It's hard to read, but this is the 85th percentile. Then that's what we consider overweight. If you're greater than the 95th percentile, we consider that obesity. When you get greater than the 120th percentile, which is right here, which is greater than 120% of the 95th percentile, or an absolute BMI greater than 35, that's actually considered extreme or severe pediatric obesity. And that is an indication for weight loss surgery, even in these adolescents at this age, because again, the less time you spend in obesity, in the obesity state, the less time you spend as a person with diabetes, for example, as I mentioned earlier, the more effective treatment seems to be. So with pediatric obesity treatment, we do have a new FDA-approved, this liraglutide, this first GLP-1 agonist that we have had on the market for adults for quite some time now, has now been just recently last fall FDA approved for children. So again, down to the age of 10, or 12, sorry. There are only a few FDA approved options. That was, the liraglutide was just recently approved. Orlistat has been approved for many years, but Orlistat I didn't really include on a lot of these graphs or a lot of these talks. Orlistat is an effective weight loss agent, but it has many side effects that are challenging, including greasy, oily stools and anal leakage, which is something that most people don't want, especially those that are adolescents during that time. There's also a drug called bensphentamine that actually is approved down to age 12 as well. It's a stimulant like phentermine. So we do have some treatment modalities for people, these adolescents, besides surgery. I'll just highlight real quickly the effects of a workplace wellness program. So while workplace wellness programs I think are fabulous, and I think we need them, we also have to do a better job in the future of how to position them, because this trial that was recently published in JAMA in 2020 unfortunately showed in a study that that there were no significant effects on measured physical health outcomes, unfortunately, with these types of wellness programs. It doesn't mean we shouldn't do them, because one thing that it did have is it increased the proportion of employees reporting that they have a primary care physician and improved employee beliefs about their own health. So that certainly is definitely a reason to do it. But just to acknowledge that workplace wellness programs are not going to be what causes significant reductions in obesity, right? As was mentioned in the video, no country, sadly, has lowered their obesity rates in the past 30 years. They've just been going up and up and up. If we're going to turn this corner, we have to treat obesity aggressively as a disease. And that's workplace wellness programs are going to be a part of that for that lifestyle component, but not necessarily going to be the panacea of making a big dent in the disease. So again, I'd like us to all have a call to action, because individually we are just one drop, but together we can really be an ocean. Leveraging telemedicine has certainly been important, and I hope to continue for any people on the call that are insurance providers. Hopefully, continuing to have access to telemedicine and have access for reimbursement is going to be key. And then what can employers and insurers do as my sort of final wrap up? I think one thing is to include anti-obesity medications and surgery and lifestyle support, which is the intensive behavior therapy programs, in your benefits package, right? So unfortunately today, most insurance carriers carve out anti-obesity medications, and it's not a standard benefit. It would be my dream in my lifetime if we could change that and make obesity a standard benefit, right? Like, we don't carve out cancer treatment, we don't carve out diabetes and say, well, if you want diabetes care for your employees, you have to pay this much extra, right? We just consider it a disease and we just treat it. And that's the way that we should have with obesity as well. And then encourage employees to seek out obesity treatment, right? And support this chronic disease model of care. This idea that it's your chemistry and not your character, reducing weight bias and stigma in the office, and use people first language when you're talking. People with obesity, not obese people. People shouldn't be defined by any disease. They shouldn't be diabetic. They should be a person with diabetes. And same, they're a person with obesity. They're not an obese person, right? And then there's the Treat and Reduce Obesity Act, which is before Congress right now. And if you can support that we could get that passed, that's going to allow for these anti-obesity medications to be on CMS, to be covered by the Center for Medicaid or Medicare. And then hopefully local Medicaids would also do the same. There is the Obesity Action Coalition as well that you can reference, which is a great website. And I just provide you with that information because there's lots of great materials for employees, and lots of materials you can use freely. Also, I'll highlight this very important tool as well, if you don't know it already. Novo Nordisk, who is the maker of some of these medications for obesity, but are also very committed as a research company to curing obesity, right? They really want to help get rid of obesity. They've been a diabetes company for years, and they would like to see that go away. So they have this novonordiskworks.com website where you can calculate the cost of obesity to your workforce or to your organization. So it's very nice because you can plug in how many employees you have. If you know their BMI, you can plug that in. You can also just use standard averages in your community. And then you can actually show how much obesity is costing your organization. So you can leverage that there's a reason for this, for the treatment. So thank you so much. And I appreciate the time with you today.
Thank you so much, Dr. Fitch. I hope you can stick around for some questions at the end. We're great. We're just a couple minutes behind schedule, so I'm going to go ahead and introduce Abby here. Abby Aberman leads the Partner Health and Wellness and Pharmacy Benefit Plans for HEB out of San Antonio, Texas. HEB is a grocery retailer that is based in Texas and Mexico. And if you've been to that part of the world, you've seen, it seems like thousands of them. They have 120,000 employees. Prior to HEB, Abby worked for Cooper Wellness Strategies and Cigna Healthcare as a consultant. She's been in the employee health and well-being industry for the past 13 years, designing, implementing, and evaluating programs for large employer groups. She holds a master's degree in public health with an emphasis on health promotion in the workplace from the University of North Texas Health Science Center and a bachelor's degree in organizational communication from Ohio University. Outside of work, Abby is a wife, mom, and competitive triathlete. With that, I'll turn it over to Abby Amerman. Thank you.
Thank you so much. Hi, everybody. I'm going to go ahead and get my screen sharing. I don't know. Let's see what this looks different to me. Let me just go. I'll share my screen. All right. Go ahead. All right.
That's perfect.
See that? Okay, good. Look, the options look different. So I was like trying to help you out with Zoom earlier, but then, there we go. It's locked when it came to my turn. Thank you guys so much for having me today. And I'm really excited to be here and share some data and some information about our employee health and wellness program. We kind of look at it a little bit broader than just that, but it's more about designing meaningful benefit strategies to help our partners reach their improvement goals, whether that be with obesity or managing their diabetes or any number of other chronic conditions. So I'll go ahead and get started. So HEB, I know I'm talking to a bunch of folks in Kansas. Some of you may have never heard of HEB. It's not HEB. We actually do spell it out, HEB. It's it stands for our founders' initials, actually, if you were ever curious about that. But we have over 10.6 million customers on a weekly basis out of our more than 420 plus stores across Texas and Mexico. We have not ever crossed over into another state, but we did move into Mexico probably about 5 or 7 years ago, and have built now a number of stores there serving, members of the Mexican community. And in addition to all of our stores, so our sort of brick and mortar footprint, we do manufacturing. We have over 12 manufacturing plants where we produce 1,700 plus products. And we do produce things like chips, snack cakes, ice cream. Our ice cream is probably one of our most popular products, in stiff competition with Bluebell, if I do say so myself. And so we've got a number of what we call own brand products. These are our products that we produce and we can put our label on, our brand on. And those are a very important part of our business. We believe that, we're producing products that are just as high quality as some of the national brands. We do have a couple of store footprints where we serve more specific markets. For example, in our Houston market, we have our Mi Tienda store and our Jovi Smart Shop. These are stores, again, that are formatted specifically for the population that they serve. So Mi Tienda has a Hispanic cultural feel. You'll find some very unique products there that you can't get in some of our other stores. And then our central market, which is what we would probably liken to a Whole Foods, where you find much more of the organic, a lot of fresh produce, fresh products that you can buy in those stores. In addition to our stores and manufacturing, we also warehouse. Of course, with all the products that we produce, we have to have somewhere to store them and somewhere for our truckers to come in and pick them up. We do have our own truckers that drive HEB branded trucks all over Texas. And we have 427 tractors, and we're driving over 60 million miles a year. Texas is a very big state, as you guys know. So in addition to HEB as a company, so we, as I mentioned previously, we really try and structure our benefits plan so that they are serving of the whole person. We want to make sure that our partners have access to great health care, no matter where they are. If they're, far down south in the border towns where there are potentially a lack of primary care physicians, but also to some of our bigger metropolitan areas where we're trying to help our partners. And we call our employees partners. So I apologize if I didn't clarify that and you're wondering what I'm talking about, but where our partners can access care that is both high quality and of reasonable cost. So we have really in-depth partnerships with all of our benefit plan carriers to make sure that we are surfacing or providing access to those physicians who we've deemed of high quality and reasonable cost. We recognize that not all reasonable cost is not always the least expensive in this case. But in addition to the benefits plans that we provide, we also want to make sure that we are providing a little bit of an incentive to our partners who are able to engage in a healthier lifestyle, who will participate in some of the programs that we provide for them or services that we provide for them. So we have our Healthy at HEB program. And really, this is our incentive program. And we have sort of been through the total continuum of wellness programs over the past 10 to 12 years. And we started where a lot of employers started. We started with a points-based program, participatory in nature, where if you walk 10,000 steps, you get so many points. And if you reach a point goal, then you're going to receive a premium reduction for your health insurance. In 2015, we moved to what we deemed a clinical engagement program, where we said, okay, partners, we want you to continue screening, but we are going to give you a premium incentive based on your biometric screening results. And so we identified our Healthy at HEB biometric standards. They're sort of the typical metrics that you would see. We're looking at blood pressure, body mass index, cholesterol, and this one, glucose. And so we ask partners to meet certain ranges. They're the very standard ranges that you would see kind of published in any doctor's office. And if they didn't meet those standards, we asked them to engage in a program that we had identified as being something that would help them to meet their goals and improve upon their health in the next health screening. So that was things like meetings with our registered dietitians, for participating in a class taught by either some of our health educators from our carrier, or our registered dietitian, or our pharmacist in some cases. We did see some success with that program. We saw some immediate success, I would say. So in the year 2 of that program, we did see partners who had improved their health more so than others who did not participate in any of the programs. But we still weren't moving the needle from a population standpoint in our overall biometric screening metrics. So we moved in 2018 into what we call a personalized improvement plan, AKA an outcomes-based program that where we ask our partners to still meet those biometric screening thresholds. And if they don't, they need to make a 3% improvement in order to earn their incentive in the next coming years, or from there, we look at the previous year's biometric screening results and compare them to the current year, and they need to meet that 3% improvement. We realized that when we did this, this was going to be something that our partners, it was going to be a little scary for them. It might feel a little lofty. It might feel like, how am I going to do this to continue to earn my premium reward? So we made sure that we had programs available to them to support them from everything from their mental health to continued engagement with clinical folks like our pharmacists and our registered dietitians. We also make sure that spouses are fully engaged. We have a tobacco surcharge, and this, we felt like we were offering our partners the opportunity to pick how they wanted to improve their health and if they wanted to improve their health. And so long as we had the supportive programs, then they would hopefully meet their goals. This is how our incentive structure kind of works today. We ask our partners, of course, to first get screened. And this year in 2021, we said if your spouse gets screened, you'll get an additional premium reward. If they have all green, which we're looking at a green, yellow, and red, designation for the biometric standards, then they will earn their full premium reward. If they have a yellow or red result, then we ask them to make a 3% improvement on their next health screening in order to earn the full premium reward. So they can earn partial, and a good number of the dollars associated with our premium reward are tied to just getting screened. So we really want to promote our partners to just go in, get a health check, figure out where they are, and then anything beyond that is just a few bonus dollars earned. So we have been screening for a long time. Even when we did our points-based program, we were screening our partners. We are at a benefit because we do have pharmacies in our stores, the majority of our stores. And we use our pharmacy team actually to complete our health screenings for our partners. So we're able to do on-site events. Our partners can go straight into the store and get a screening with the pharmacy team within designated hours. And so with that, we've been able to kind of build this really awesome cohort. So it's the partners who've participated every year since we started this. The results I'm sharing with you today are from 2019. So in 2019, we had exactly 10 years of data for our cohort. And they're about 50 years old, almost 51. The breakdown is 56% female and 44% male. And we still have around 10,000 partners remaining in this cohort if we look at all 10 years. Of course, if we broke that down a little bit further, it would be bigger, but we typically have about 35,000 participants, give or take, participate in the health screenings on an annual basis. We do have a fasting glucose cohort. We always have to call it out because we started it 1 year later. So it's just one year less. It's a 9-year cohort in this case. Again, it would be everybody who had a fasting glucose measurement from 2011 into 2019. So in addition to our screening demographics, I also wanted to just kind of give you an idea of what it looks like from our medical plan and our pharmacy plan. When in 2018, I'm showing you here just our average BMI in this kind of tealy green color and our obesity rate. So this is anybody that had a BMI over 30. And then over here for 2020, I was able to pull in of our total membership, how many were utilizing or had a claim for obesity related services. So for the pharmacy plan, it was who was taking an AOM. And for the medical plan, it was who was actually diagnosed and had a claim for obesity. So as you can see, over the course of the years, we have kind of stuck around this average BMI of 30, 29.9. We reduced a little bit. And our obesity prevalence has been above 40. And then in 2020, we were able to bring it down slightly, just around 40%. And this again is of our total population, not just the cohort. And so when we look at our claim specific data, you can see sort of the discrepancy between what we know about our people and then who's actually taking advantage of the benefits that we're providing to them and the opportunity for them to use things like medication and physicians to help them manage their obesity. So we've got about 6% of our total membership that has opted into our anti-obesity medication. And it's only 2% who actually have a claim as obese in our system, which is amazing. We do know that in Texas, physicians are not using obesity. They're not coding for it. It's not coming through in claims. So we do think that we have some work to do there in just educating and trying to help physicians make that connection so that we can continue to see more of a relational component between what we know about our population and then again, who are utilizing the services. So I mentioned anti-obesity medications, and we did sort of hem and haw about this a few years ago as to whether or not we should offer this as another supportive plan design offering for our membership. It was one of those things that I think, being in benefits, you may have sort of a bad taste in your mouth for anti-obesity medications potentially, because there's a lot of news. I don't even know how many years ago, a long time, just how these can be dangerous or people had bad side effects. And I sort of had to break that stigma in my head about anti-obesity medications as well. So I wanted to just share a little bit about what we went through in order to determine whether or not it was right for our organization to cover them. We wanted to know, of course, the need. So how many people in our population could benefit from this? And as you could see on the previous slide, we've got quite a few who really could benefit from trying anti-obesity medications. We looked into our utilization of anti-obesity medications even prior to them being covered. And we did see that there were a number of our members who were actually paying out of pocket for phentermine, which is the generic brand mostly, and who were utilizing it. So we thought, okay, some people know about it. Doctors are potentially prescribing it. So we thought that was a really good indicator that we could have some people who were interested in it. The second thing was to go in and sort of try and break the stigma. We wanted to make sure the team was fully educated on what anti-obesity medications did, what they can do, and how they could really benefit our population. So we asked our physician friends. So we have an on-site clinic, so clinicians from our clinics. We asked some medical directors from some local hospitals that we have good relationships with. And then we also were able to speak to a lot of the manufacturers like Novo Nordisk and others who were able to bring their clinical experts in and teach us about their drugs. And that was really, really helpful because it sort of brings a whole new light to what these medications do and how they work. So that was really helpful in educating some of our, our leadership teams to feel more comfortable with potentially offering this. And then finally, we did ask our PBM and our account management team to build a financial model. We wanted to understand, how much our partners would be paying out of cost for these medications. How can we supplement those costs potentially, make some assumptions about how physicians might prescribe the medications, what we would have to pay for our prior authorization costs and things like that. So those were some of the things that we did in order to kind of make a plan for start beginning to cover anti-obesity medications. So where we landed was because we have our own pharmacy team and a pharmacy team that actually we have a small call center where pharmacists and pharmacy technicians sit and staff the phones. They take calls from our customers and also from our members of our health plan. And so we employed them to help us and create a program where we could manage our own prior authorization process. So what we did was we said, okay, we're going to cover these medications, but in a lot of cases, the generic medications were cheaper than what we were paying for any kind of prior authorization that would go through our PBM. So we decided to just kind of pull that back, utilize our pharmacy team to ensure that people who did decide to take these medications were staying on track with them. They were meeting their goals from a BMI standpoint. They were continuing to engage with their physician. And so what we do is when we get the prescription in the pharmacy team through the call center that I mentioned confirms the diagnosis with the physician directly. So there's a form, they call the office, they ensure that the partner again is staying up to date and up to speed with their required BMI metrics and their weight loss goals. And then our member is able to pick up the prescription, and upon each refill, we sort of go through this process again. And so our members who engage in this process with our pharmacies are going to pay less for their prescription on a monthly basis. So if somebody gets their prescription, they don't want to play our game, they can still get it. They just aren't getting a lower copay as a result. We have found just in about a year, yes, we have had a full year of covering this medication, 83% of all of our scripts filled are generic. And what we predicted our costs to be, we're only seeing about 25% of those costs that have actually kind of come to fruition. So we're paying less, way less than what we expected to be paying for these anti-obesity medications. So it kind of ended up winning out. Now, would we like more participation in this program? Yes. So we'll continue to promote it and help our partners and members to understand the benefit of it. So in addition to our pharmacy plan coverage, we do offer our partners some other ways that they can improve their health. I mentioned registered dietitians earlier. We actually do have a team of registered dietitians that are HEB partners. So they go into our stores or they offer telehealth visits these days. And they work with the physicians in our communities to help them to understand the benefit of having a grocery store-based dietitian work with their patients. They can do meal plans, they can do recipes, cooking demonstrations, all sorts of things. They're a really wonderful resource for us, and we're so lucky that our partners can go to them. And we decided with our plan design that we would let our partners get 3 free visits with our registered dietitians on an annual basis. And then after that, they just pay their a $30 copay. We did see when we were in that clinical phase of our health and wellness program continuum that we had a proven ROI in health improvement for our partners who engaged with an RD. So we do believe that there is value there. We've also tried some different digital therapeutic type coaching programs. We currently actually just last week rolled out a new one on Duo program. We've seen great success with this. Our partners really like the widgets and the tools and the engagement from a health coach. And so we're hoping to continue seeing some weight loss and also just other improved metrics for diabetes through that program. We also worked with our EAP and our mental health network to identify counselors who specialize in behavior change and motivational interviewing. And so our partners have direct access to this network of clinicians who can help them with their goals. And that's been really helpful from a behavioral standpoint. And then again, we continue to do our screenings, and we have this digital health coach. That's her right there. You can barely see her, but she's a character that we sort of bring out when we're trying to advertise and promote the Healthy at HEB program and offerings. We've created a whole library with videos of her, articles, things like that. And previously we had a requirement where you had to watch a video, or if you did watch a video, you got some additional premium reductions. And so she's become a really great character for health education in our Healthy at HEB structure. So all of these supported plan design offerings and our outcomes and based incentive program design has led to our partner health improvement. In 2019, we saw for the first time a significant decrease in change in our prevalence of all of our risk categories. And this chart, forgive me for being so busy, but it's really the best way to demonstrate sort of what happened, because you can look across the colors here and see where there's increases and decreases. But we, in 2019, as I mentioned, we did see a 4% in our total population. This is everybody who screened in 2019 in a reduction in just prevalence of obesity. Also with blood pressure, cholesterol, and blood glucose. So we were really, really thrilled for the first time to kind of see these measured improvements in our cohort population. And then when we looked at, this is our cohort population. When we looked at our cohort risk prevalence and the change in 2019, same thing. The only one that did, or the two that did not improve since 2010. So from the inception of this program, and keep in mind, this population is 10 years older than they were in when they first started screening with us. We did not improve in BMI and in blood glucose, but our year-over-year improvements were there for all four, again, of our risk categories that we look at when we screen. So we were really excited to be able to report that out to our leadership sort of after 10 years of really, really hard work. We found something that worked for our partner population. And just some additional improvements that we made. When you look at the total number of risk counts, so we're looking at all four of the metrics. We have a fifth one there because we've got two blood pressure numbers. So technically we're looking at 5 risk categories. We reduced the number of risks, so the count of risks that our partner population had over time. We also offered an improvement bonus. So partners who met all of their improvement goals, no matter if they were red, yellow, or green, we were able to pay them an additional improvement a cash bonus, and we were able to pay that to 33% of our screening participants. So we were really excited about that. We felt like we kind of learned a little bit about behavioral economics too. So we put this goal in front of you. We kind of said, reach for 3%. And some people took advantage of that. So I thought that was a sort of an interesting side result that we figured out. So as we move forward, I'm sure like many of you all, 2020 has thrown a curveball in all of your grandiose plans, much like it did mine. We only were able to get through a portion of our screening campaign last year. So I think we had just about 11,000 of our partners complete their screening when we had to pause our screenings. So we're looking forward to starting our screenings again. The plan is to start in June once our pharmacies get a little bit settled from giving the COVID vaccine and all those other things, but we're looking to start that up again. And I do think it's going to be interesting to see what happened with our biometric results. We know that there has been some probably significant change in health status, if you will, over the past year. And so I think it's going to be an interesting one for our partners. So right now we're really promoting, hey, how can you get ready for screenings? How can you get your health back on track? And we're doing that through just different communication campaigns. You see here the nutrition services campaign and our condition management program, which is our copay reduction program for weight management, diabetes, and asthma. And as I mentioned, we also just rolled out our new virtual diabetes clinic through OnDuo, and we're hoping that those are some ways that partners will kind of kickstart their journey here in 2021. We're also looking at continuing to analyze our data in ways that we haven't ever before, and that includes a project looking at our population who's taking our anti-obesity medications and their screening results, their success in the program, because we are tracking all of that, the diagnosis and the BMI and the weight of all the participants in that program. Hopefully we'll be able to see some really interesting and unique findings based off of the participants that are, or the people, partners, members that are taking anti-obesity medications. So that's what's next for us. We're hoping to get back on track after COVID, and we're looking forward again, as I mentioned, to getting everything started back up again. So that's all from me. So I'm going to stop sharing, and I think we definitely have some time for questions.
Well, thank you, Abby. That's a very interesting talk and a really novel approach to worksite wellness. We're really appreciative of you coming to speak to us.
Oh, thank you.
I have so many questions, but I think I'll open it up to the audience before I start holding forth. Any questions for Dr. Fitch or for Abby from anyone in the crowd? Feel free to chime in or raise your hand or get our attention however you like.
This is Shelley. I have a question, Abby. Have you considered coverage for bariatric surgery at all?
Yes. Actually, we do. And I should mention that more often in this presentation, but it's a little lopsided. So we've got some work to do. We actually require our plan members, if they want to get a bariatric surgery, to pay an additional out of pocket. I guess you could call it a copay. It's quite significant, however. So we do think that that's a detriment to our membership and a reason why they may not choose that as a preferred route for care. But we do cover it with an additional out of pocket requirement for the member.
Other questions? Dr. Fitch, in my I'm an endocrinologist, in my little corner of the medical world, over the last few years, there's been this growing, still small, but growing movement of weight agnostic or weight neutral diabetes management, where patients are promised not to even have their weight mentioned, and in some cases, the doctors promise not to even weigh them. And in return, they get extra focus on other behaviors, risk factors, whatever. Do you have an opinion on that approach?
So I do think in all things, right, we have to be cognizant of the patient's own desires, right? So I don't think, well, I think that, treating obesity is very important. I do think it is like any other treatment, there is also shared decision-making and personal choice around it. And I think, a weight is certainly a metric, to us all, like a blood pressure and other things. I think it's important. But again, I don't want to force weight loss on anybody or judge them for not wanting to, right? So, but I do think, the data, the science shows us that weight loss does produce better outcomes, as it relates to a lot of things, and especially for people with diabetes. So, while I think, having that discussion with people is important, and to understand where they're coming from, and then to work on that, to work on whatever they're willing to work on, or whatever they're able to work on.
Yeah. Questions from anyone else?
I have another question. Dr. Fitch, I was just curious on the medication, the newest one that may be released here shortly. Can you talk about the side effects? And then also, once someone loses the amount of weight they need to or want to, do they discontinue the meds, or how long must they remain on the medication?
Yeah, so I touched on that a little bit in the slides, in showing that when you stop the medication, the weight comes back on.
Yes, I'm here.
Yeah, so I think the issue is that it is something that's very challenging for people to understand, and it does sort of also advocate for surgery, right? Because if you have surgery, you then don't need those medications. So the biggest side effect of the medication is nausea of that medication in particular. Other medications like phentermine and topiramate, biggest side effect there can be some feelings of stimulation or anxiety sometimes, feeling of sort of your palpitations or other types of sensations, dry mouth, et cetera, with some of those medications. So, depending on the medication, there's always side effects, and you always have to weigh those side effects and the benefits, depending on the patient. And that's why we do look at, we want people to lose 5% of their weight within the first 3 months of treatment. And if they're not losing 5%, then the recommendation is to stop that medication, because it's not helpful. Like I said, there are responders and non-responders. So you don't want to take something if it's not actually producing benefit.
Dr. Fitch, Abby, thank you both for your presentations. Some of the questions I had were answered through some of your other responses, but it was a great presentation, great information. Abby, I do have a question for you in terms of things like obesity medications. Is that something that the employee would self-select to take, that they would determine that they would like to look into that, and then they ask their provider about that, or are they somehow identified through your benefit plan as a possible candidate for an obesity medication, or how does that process work among who gets it?
Yeah, so we've done a little bit of both of that. Obviously, first and foremost, educating them to feel empowered enough to ask for it from their physician if they feel like that might be something, and have a conversation with their doctor. Of course, we're not over here saying you definitely need it, or we've never told somebody that. We obviously look to the physicians to make their prescribing choices. We have been able to target communicate, if you will. So gentle kind of letters like, hey, did you know we now cover anti-obesity medications to a targeted group of members, so that they just know about the new benefit offering. So there's a couple of tactics that we took originally. That the sort of I guess total population view of this is that we talk about all of these programs on an annual basis and in between for annual enrollment and things like that. We have a group of we call them admins. They're an admin in every single department within all of our work locations, who are sort of our feet on the street. They go out, they really help us get the word out to our partners about benefit offerings and plan design changes. And when this one came up, this was one of the big it was one of the big topics that we asked them to make sure everybody was aware of. Those are the ways that we've tried to communicate the benefit offering to our members.
Abby, I have a bit of a follow-up question to that. When you switched from the kind of participation-oriented program to more of an outcomes-oriented program, did you get any, and I may be putting you on the spot here and I don't mean to, but was there any pushback from your legal department or anyone else about the possibility of this being discriminatory? Some people may just be genetically prone to having better health markers.
Yeah, we work very closely with our legal team and privacy team, of course, as you can imagine. Anybody who runs a wellness program has to, because things seem to always be changing and there's always something new to consider. But yes, it was, I had just started at HEB actually when we were, well, it had been a couple of years, but I was the one to go and promote this type of program to our leadership teams. And it was a scary day because there were a lot of folks who probably were very opposed. But at the end of the day, the way that we've tried to communicate it and we've tried to promote it is, kind of your improvement plan. We want you to be healthier. We want you to make the choice to participate, things like that. And so we've just tried to be very careful in how the program is communicated to make sure that it still is presented as a benefit to them. It's our premium reward, honestly, is not a lot. We've been very careful to make sure that it's not, something that is more, the money is sort of driving people to participate in the program. And we did see a significant drop off in the number of participants that we had when we first moved to this program. So potentially people just opting out and saying, not interested, I'm never going to make it, so therefore I'm not going to participate. So we did see that. And I would say that's probably one of the bigger things that was concerning for us. So yeah, it's definitely a daily, something that we think about, something that we're analyzing and considering as we move into future years. Good question.
Other questions for our speakers?
Hi, this is Debbie Williams. I'm Dr. Fitch. Can you talk a little bit more about why insurance won't cover either surgery or medications, and maybe what we can do to move that along? I love the fact that you look at this as a disease, just like cancer, and we wouldn't think of not treating the cancer patient. So could you talk about that a little bit more?
Yeah, I think it's related to this idea of stigma bias, or that one of those early slides I showed, that even 82% of people with obesity feel like it's their own responsibility to treat it, right? That they can fix it themselves. And I think that's ingrained in all of us, right? If 82% of people, that's ingrained in the whole society, that this is something that is not the chronic disease model of care, right? And so I think the more we see it as a chronic treatable disease, that's the other factor too, is for years it was thought that it was just, people need to just fix what they're doing and they'll be fine, And so I think the more we can all of us here, move that needle and like what they're doing at HEB and show that that this is a something that there's help for, right? So many patients that I see, they say to me, oh my gosh, I never knew what it felt like to be full. And when somebody never knows what it feels like to be full, I mean, that's like amazing, and they're just like blown away by the fact that they've lost, this 50 pounds, with the help of these tools, right? And so being able to do that, or 100 pounds, for some people, right? So just, I think, hopefully in the future, that won't be the case. That's what we're trying to change at the Obesity Medicine Association and other associations, is trying to change that paradigm that this is a disease and not something that should be sort of electively covered, if you will.
Well, I think we ought to start wrapping up. We're coming up within a couple minutes of our end time here. I want to thank our speakers again. And I think Matt had a few things to share in terms of the nuts and bolts here before we get off the call.
Yeah, I would just like to again thank Dr. Fitch and Abby for coming and sharing. I hope everybody learned as much as I did. There was some really great information in this program, and I hope there's some actionable things that you can take away and implement in your own work site. I just wanted to remind, as Dr. Moore mentioned at the beginning of this, the Kansas Business Group on Health does have some funding through the Centers for Disease Control that's focused on diabetes prevention. And so we do have some money set aside if any employers out there would like to pilot a program such as the Diabetes Prevention Program to do some of the healthy lifestyle behaviors that both Abby and Angela, Dr. Fitch talked about at the beginning. So if you're interested in that, please contact us. We do have some other programs coming up that we hope you'll join us for. In April, later this month on April 20th, we'll be doing a program on how to use data to craft your benefit design. It'll be the same time as this program at 10 a.m. on the 20th. We have two programs in May, one on telehealth, and then one that I think a lot of the wellness folks in this group will be interested in. We'll hear an update on some of the rulings from the EEOC lawsuits from Yale and others that affect wellness programs. So Al Lewis will be here to tell us about those updated wellness rulings. And so we hope you join us for that. And then we also have our 43rd annual healthcare roundtable coming up in July. To learn more about any of those, just go to our website, ksbgh.org. And if you have any questions, please reach out to Shelley, Dr. Moore, or myself. With that, Dr. Fitch, Abby, thank you again for coming and sharing with our group. Thank you all for joining us, and we'll talk to you soon.
Thank you.
Thanks again.
Thank you for having us.